screen you,
Uh,
and then I'll introduce you.
it's good. Shall I put up my slides now,
Yeah,
or
sure, and I'll introduce you. Might as well do it.
uh,
Well,
okay? Share slides. Okay.
if that works.
Let's see where.
While you're doing that, I'll introduce Joost. Is
Yeah,
oh,
yeah. I'm trying to find out where these share slides is.
oh yeah, but this should be made a co-host. So um, Selma or
Yeah, he should be all good to share screen there. Just down in the bottom of the screen, Yoss, in the middle.
In the middle.
the green button
Okay. Yes.
says screen. And then we will select the screen.
Okay.
There we go. Okay, perfect. Let's put on slideshow, but I will introduce you first. I'd like to introduce Dr. Joost Aarts, who's been from the Netherlands, who's been a professor there at the Erasmus School of Health Policy and Management in Rotterdam. He's also an adjunct here at UWEC in the School of Health Information Science. I've known him for a very long time. He in 2017 he retired from Erasmus. He's also been a research associate professor in Buffalo at the State University of New York. And
Was.
yeah, that's SUNY, right? SUNY Buffalo.
Yeah, was. It's already. Yes, I'm still with you.
Yeah, and here as well. So yeah, if you know Roche, you know he does work in socio-technical systems and design of systems. And the interesting thing is, he also went back, years after doing a PhD and did the MSc in the history and philosophy of science in health informatics. I think that's really neat. So I will just pass it on to Joost. Thanks.
Okay, thank you, Andre, for introducing me, and I'm glad that I can share the outcome of a study that I did on the electronic patient record in the Netherlands. Actually, after my retirement, and especially when my projects were ended, my wife said to me, "Yeah, I don't want you all the time around in the house, so do something." And I took the opportunity to go back to grad school as a student and take the regular courses of a master degree, but also write a thesis on the history of the electronic patient records, something that I wanted actually to do, but I felt that I needed a training as a historian in order to do it properly. And even then, I'm learning on the spot. It was quite an experience to be changing roles from being a professor to being a student, and especially when my professors sometimes made fun out of me, like, "Oh, you professor." Okay, I'm going to talk tonight about the histories of the medical record, and what I will do tonight, or this afternoon for you, is that I will try first outline a little bit about the concepts, how was my study driven, the beginnings of the whole thing. Then I will talk a little bit about medical computing in hospitals in the Netherlands, computing in primary care, which is the fourth theme, and I will already tell you that will be a very interesting and an important issue. Then the next phase, when patient safety, quality, patient rights, accountability, and audit became more dominant in the history. And the epilogue, I will talk a little about the thorny issue of sharing medical records across organizations and with patients, which is still a very challenged thing. And finally, I will talk about the methodological issues that that come with doing research, and a conclusion. First, I chose to position my history study on the role of the physician or the provider in healthcare. And I was also driven by the fact that it is actually impossible to say we have an innovative technology and bang, we had an electronic medical record, or we have pioneers. Those were the important people who invented it. That's also not really the case. Actually, and that is it, you see in the books that I here present. To the left is a book studied by Mark Burke. In the middle, I will talk a little bit about it, and then at the right, a sociological study of hospital care and how hospitals emerged in the 20th century to understand how context shapes technology. But on the other hand, Mahoney, a past professor of history of science and technology at Princeton University, already showed that writing about history of computing is extremely hard. It might look simple because you are yourself more or less witness to that history, but you have certainly as a non-historian less understanding of what the position is. Furthermore, every time when the development takes place, it constrains choices, and that's what Mahoney tries to say by quoting from Rob Kling and Wal Sketchy, and also quoting a Bjarne Stroustrup by saying, a history of computing is not starting with a clean slate. That the table is open and that you can start from there. So, summarizing in these concepts, you have beginnings and a context. The question is, what are the beginnings? I let the beginning start with the reform of medical practice, which certainly in North America proved to be very important. A electronic medical record, that's the socio-technical perspective, is an active device. It cements relationships, and you call it the socio-technical, the STS perspective. And there is I chose a context of institutional health system influences power, if you will. If you talk about technology, you have always asked the question, who's controlling what? And of course, the affordances of computing, it constrains and enables. These are the two factors that are playing a role in understanding that history. The beginnings. My conclusion is that you have to look at the reform of medical education and medical practice at the beginning of the last century. And one of the things that the practice of medicine was basically a mess in the United States and Canada. It was a mess because at the one hand, there was a need for more healthcare because of the industrialization. And on the other hand, there were no formal requirements to be a doctor or a nurse. So Flexner came in as an outsider, as a consultant to look at medical education in the United States and Canada. And one of his conclusions was that students should learn the latest of science and technology, but also learn from structured records, because records at the time were, despite reforms, basically handwritten notes by the doctors, where they put down the observations in a very disordered manner. And so if you want to structure medical educations, you have to learn to restructure your records. The one other thing is that you should also look at the question, what are your products? And that was the famous Ernest Avery Cotman, who defined the notions of outcomes, which were for that, in order to know, you had to have a structured record. Here you see a quote, a diagram from his studies, his papers that were published in the early, around 1910, 1913. And the Flexner report, which you might know, was published in 1910 as well, around that period. So there was a huge transformation of medicine, science-based, a reform of practice in medicine. Abraham Flexner, and not Avery, but Abraham Flexner and the American College of Surgeons were the events, were the person's events that led to the structured records, and there were reforms in medical record keeping. Initiated, Abraham Flexner, initiated by the ACS and initiated by Ernest Avery Cotman. And they look like this, printed forms with names you could find organized. And already in 1921, 22, tabulation machines helped to collect data about patients, to record them, and even to analyze them. So already before the World War, we had the notion of a structured record, which was very much alike what we saw after the war. And the technology was used to also analysis of populations of patients in line with the notions of Cotman. So the structured record, complaints, these are things that you recognize: complaints, findings, diagnosis, test results. There was a standardization of disease terms and measures. Is centralized handling and storage by clerks, and manual extraction of data and mechanical tabulation for research and hospital planning, to know how large the hospital should be, and how much specialist care would be needed. And I can say that it was major, more or less, by 1940. And actually, I did not look at that further, but I can say in the United States, it was an important moment, an important phase to make the next move towards computerization after the war. I jump now to the Netherlands. The same reason, the Dutch doctors were very reluctant to take on the American examples. They saw nothing in it. And they were well aware of it, because I have documentation that they already knew about American developments in 1928, in the period 28 to 35, 1935. But they rejected out of hand and said, if you start counting about patients, then you lose the doctor-patient relationship. And they were very reluctant to have any notion that another body, like clerks, but also other bodies, government, hospital administration, would look over their shoulders and look and see what they were doing. So only in the 70s, with the burgeoning growth of hospitals, the need arose to have more data, to plan care, to estimate how much was needed, to have more cost accounting and the like. And that was the origin of the BASIS project in Leiden. That was the first notion of a hospital information system to store medical data, but also administrative data about patients. And Bakker, also in an interview to me, he said we left purposely the doctors out. They were very negative and it would take too much time to get them on board, so we didn't even bother to bring them on board. The report, it was well documented and well evaluated. So BASIS, and I think Dennis is I believe Dennis is there, he will know that BASIS was much published about and said as an example how you want to build a hospital information system. And there had been certainly within the EMR context a lot of meetings about how to do that. And these reports that were evaluated played an important role. However, there was again criticism that the medical records were actually an unorganized bundle of words, patient observations, etc. So the doctors agreed and kept the government at a distance to say, how should we structure a paper-based medical record? And I can tell you, BASIS was long underway, but only in 1976 they reached a agreement across the Dutch hospitals how to structure, what to write up, the general information, diagnostic information, etc. So the medical computing could not even start, computerizing medical records could not even start in the early 70s because there was no basis for creating a structured medical record. And these were the publications that you saw that were actually stepping towards that structured approach. Now here I summarize a little bit. We had an unprecedented growth of medical specialist care in the 50s and 60s. Collecting and analyzing medical data was needed for planning, especially for resource planning, but also for clinical research, which came up. You must imagine that the notion of population research, study of patient population, is not that old. A foundation was established in order to come to such an approach. And in the meantime, healthcare costs came aboard, so some form of control was needed. And what I say is that recommendations for a structured medical record were created, but the electronic medical record had to wait for another 25 years to come. And that was, you talk about in 1975 around. But it is not that it was a jump. When Windows-based computers became available, a smart doctor in the Netherlands showed, okay, we have already this hospital information system, but let them show on a screen in a very interactive way, not interactive way, but usability sphere, to quote from Andre, that they can see the data about the patients that are collected by others in the hospital information systems. And that proved to be a huge success. Now, primary care, a whole different story. Because of the unprecedented growth of medical specialist care, primary care became actually marginalized. Primary care doctors were ignored. They were seen as quite stupid. They patients had usually direct access to the hospital, so they were bypassed. So there was a need to reinforce the position. So in 1956, 57, the Scientific Organization for Primary Care was established. And one of the tasks was, we cannot establish ourselves unless we do research on our patients, and especially population research. So the way of doing that was to have a structured record. So in 1957, a model was created, and you see that in this green card, a paper model on which the primary care doctors could write basic data, findings, the whole thing about patients. And it was structured in such a way that he could already, or she, there were at the time very few female doctors, pick out patients that needed special attention, like diabetes patients or patients with cardiological problems, with little tabs that he could, with putting a pen and a needle, and lift out of his drawer record system. And in 2015, the GPs revised their guidelines, but was still based on the work was done in the 50s. Okay, I stay for a little moment with this. So it is interesting to note, Jan van Bemmel started with this already in place. And what he did was set a program to translate those notions of the green card, as it was called, into an electronic medical record. And before that, already in 1979, the doctors had already, the primary care doctors had already adopted the notions of the problem-oriented medical record by Larry Weed. So, and that was the basis of the work of Jan van Bemmel that started in 1982, when he eventually, at the end of the period, could report that, and in an article by him and Johan van Leij, that about 90% in 1989 were using the electronic medical record of the GPs, which was a huge number. But the basis was laid in 56, 57. Then came 90. I think everyone knows about patient harm, emergence, medication errors. The emergence of medication order entry systems can be placed already there in the Netherlands. And of course, we know that it in the United States started earlier, 1972, with the El Camino Hospital. We got more legislation about the quality of care. So the government said, okay, we need to have better outcomes. And what's important, a law was introduced, became effective, that said the relation between a provider and a patient should be contractual. Should be contractual with rights for patients. And we saw a complete new reimbursement system, medical products, and the medical specialists chose to define their own products. And finally, an increasing role of regulatory bodies, public and private, to manage, more focused on the cost containment and quality to our healthcare system. So we saw all kinds of contextual events. All these, apart from the first bullet point, had little to do with computing in healthcare, but would set the conditions. So it had consequences. And of course, major is like this. to Err is Human is the kind of the quintessential report that made a lot of people nervous. We had a tick box approach in healthcare that translated into computing. And we had a reimbursement system which became very complex, but required computing and defining medical products as well. Okay. Sharing the medical record proved to be a huge challenge. Here you see three little pictures. I will tell a little bit more about it in the summary. But first of all, there were experiments that showed that communication of data between different echelons, between primary care hospitals, between doctors and laboratories, did work well. These experiments were widely published and also found their way in our now known medical informatics journals, showing success. Reality was different, was no success, because what had happened is a successful project died in beauty, or no funding, or there was no interest in wide implementation. So, and there was so much concern about privacy. So about 13 years ago, when notions of collaboration became more accepted, the upper chamber of our parliament rejected out of hand sharing of medical data. So we were back to zero. Only this year, new legislation has been adopted, and this requires communication, electronic communication among providers and organizations. And I'm sitting on one of those committees to define data for prescribing for medications. So here we see the summary. Messaging in health, lab results, appointments, discharge. Interoperability was a real problem, and actually up until today, it remains a problem. And it is not a technological problem, but a problem of who controls what. The vendors in the Netherlands were very opposed in terms of that they said they were of course very conservative about patient privacy, but they say we also want to protect intellectual property rights, and we have our own standards. So, but also hospital organizations, hospitals were reluctant to share patient data because if you would share them, you would lose your patients, and a filled bed is a paid bed. That was the mantra. So different parties coalesced to halt interoperability, to make it extremely difficult. And the data protection concern killed legislation. And what happened is the government left computing to the market, so there was more or less chaos, and market forces determined what happened. But it was also clear that patients had an intrinsic, because of contractual agreements, had an intrinsic right to access their data. And patient organizations started protests. We can't access it. It is very hard to get to have doctors show, or also nurses show our records, what they thought they should be able to see. And it was written in the law that paper records could be seen by patients, and errors could be removed, like wrong data. But doing that electronically proved to be a hurdle. So new legislation was introduced that stipulated that a patient has a right, should be able to access his or her medical data through a patient portal. Now, that was enacted eventually with the say that it should be standardized, but it was successfully obstructed by hospitals and vendors. And now the government has adopted new legislation, the WEGIS in the last bullet, to put pressure on the different parties. And now you have to share data from your electronic records. It requires then standardization across the board. Moreover, you saw the European Health Data Space. That's the new kid on the block, in which the European Union says we need to share data across the countries of the EU in order to make possible that the patient can see or can be treated properly when he is in a different country. And that legislation has been adopted also at the European level and also needs to be implemented. So you see that my history, which you can find in later on the last page of the slides, shows that all kinds of external forces that at first sight have little to do with computing standardization determined very much the field, the nature of medical computing, or which means the nature of electronic health records. Moreover, because the government had left all things to the market, to a regulated competing market, that we have now one vendor that dominates 80% of the EHR systems in the Netherlands. That's Chipsoft and Epic, the other 15%, and we have still 5% left. And I know by now that these 5% are smaller vendors, also from one from US and one from Germany, and they are already being pushed out of the market. So basically the market will be shared by two major vendors, Epic and Chipsoft. So that is the situation, which leaves also the patient, but also the hospitals in a very oppressed situation. There is little that they can do. Okay, so that's the end, and that is very close now. Only in 2015 the paper-based records were gone in the hospital. I know one hospital that only succeeded that in 2018, but around say 6 to 7 years ago, the paper-based record was history. Of course, when you do history, you run into methodological issues. First, the historiography. As a historian, you look who has written about the history of electronic health records or biomedical computing in general. How it was done, and what approach was chosen. So how does it contribute to the body of knowledge of history? And I must say, despite my respect for Morris Collin, until recently, the books that were published, one by Amy and Morris Collin, the history of medical informatics in the United States, then some books with Springer, they were basically a summary, a compilation of facts. Little analysis, you would see, then was this person active and he developed that person. And look at those books that probably are sitting on your shelves too. It's a tabulation of facts. So the historiography is very poor. However, there are now a number of historians in the field, very few, who have produced very interesting books on the history of medical computing. And one by Jeremy Green, on with the title "The Doctor Wasn't Here," about how he shows how current technologies already find their roots or saw similar problems already back to 100 years ago. Andrew Leah, who wrote a study of digital diagnosis, how to make diagnoses with the help of computing. And we have also Joe November, who wrote about the role of the government in the early 60s and 70s in biomedical computing. So it is growing, but very slowly. And my claim is that writing history is a skill and a intellectual skill and by its own right. Of course, data sources, what do you do? Archival. Now, I can tell you the one thing that I saw immediately, that important archival documents were simply not there. Of course, already in the 60s, there were journals like Methods that published about biomedical computing. But as a historical source, how decision making came about, what were the elements, they don't. Such a journal doesn't tell you much. So my scientific papers have become a primary source in order to see, can I construct a history based on what I read in the papers versus, for example, interviews. Computing is volatile, so you have to think about. I think many of us, you, Andre, and usability, would love to have looked at the screens that were used, say, in the 60s, 70s. I had my own issue. I'm part of the history, so I have to distance myself. So it is very convenient. So I know the people, I understand the context, but bias is a serious risk. And doing oral history, which I did, human memories are fallible. So I did it, but I always, when there were claims or statements, it was always that I tried to double check with other information sources. An important question is, how far in time should one go? My conclusion is you have to go far earlier than the Second World War, than even when computing started. And certainly in my work, I had to deal with sociological thinking, which I used very much in my active life as a researcher. And of course, I'm still active, hope to be active as well. But as a sociologist, you have a different perspective on computing with observation studies, all kinds of studies, versus historical thinking. And what did I choose not to address? You have to leave out many things. I chose in my study to look at the position for the of the doctor, especially at the influences that are there, power structures that are there, and that meant that I left a lot of things out of my picture. So choices are you have to make them, but you can indeed tell interesting story. But my challenge is also, if I have so many elements, what can I pull? What can I pull to a more higher level of thinking about history? My conclusions. There are multiple histories to be told about the electronic medical record. That's why I used to use plural. There is not a single concept object. It takes its shape in the hands of the people who deal with it. My conclusion is also that the electronic medical record was less the result of pioneers and first in technologies than circumstances and affordances of computer technology. I think in order to understand what we have now, we need to know about what went before. a structured paper-based medical record. I think it was necessary phase, but not the sufficient connection. And the other thing, planning and accountability, which is really something of our times in medical practice, led to the emergence of electronic medical records in hospitals. So that's why we are still struggling that hospital information systems, EMRs, in hospitals have still an administrative perspective because of that history. The need to emancipate primary care and grounding on scientific evidence led to the electronic medical records in GP care. And I must also add to it, the costs of implementing EMRs in primary care was much less expensive than in hospitals. So you talked about budgets that were basically affordable for doctors. And I would say many stewards, many different people made the EMR possible. And my elephant in the room is the libertarian medical specialist. I have a quote from a medical director in the Netherlands in 1931 who described American medicine as fascist. And now you will probably jump on the table. But fascist is not in the meaning as we know it now, but something that bodies exert influence on the behavior of doctors. And that was for a Dutch doctor, anathema. No way. So, and I think that also, despite the nursing, I have been active in nursing for a long time, you know that still determines also the nurse-doctor relationships. It's being challenged and it's changing, but that history is still there. And I think that Elizabeth would agree with me on that, despite progress and enormous progress that we have, that is made in the nursing professions and the allied health professions. Of course, I want happy to share information. You can email me and ask questions. I have 2 emails, also on UVic. And you can download my thesis on this site. It's open access. Or if you want to use it, fine with me, but quote. So it complies with the notions of now what we find important about open access. And I hope my aim is, maybe I could certainly use help from you, is to expand this thesis to a more a book. I think with also with Springer that would deepen, would delve much more into the findings that I have, and with the help of additional archival sources. And my idea is to make a comparative history between America and between the United States and the Netherlands, since I'm quite familiar with both countries, and see how different they are, despite that we are. And I can already show that America is much more regulated in terms of health computing than the Netherlands is. And this is my story.
Thank you. That was fascinating. Actually, if you can, let's share in the chat some of those histories you recommended. You mentioned Jeremy Green and a few others. Your comment is interesting because I agree, a lot of the histories I've read in this field were done by participants and essentially were dry facts. They weren't,
Yeah.
You were a participant, but also an observer as a historian. And I hadn't seen a lot that, for example, in the history of personal computing, there's lots of great documentation, like Walter Isaacson's book on Steve Jobs and many others. But a lot of the stuff appeared kind of dry when I went through the original history of medical informatics. And now that you mention it, they often seem like these were the things that happened or the systems that were developed, missing a historian's perspective. So those recommendations might be interesting to look at, and I think that was fascinating the way you're looking at it as study as a historian. Hadn't seen that before.
Thank you, Andre. Yeah, it was also for me a new learning experience to look at history. So I can tell you that for my coursework, I wrote essays on Newton, about the reception of Newtonian mechanics in the Netherlands in the 18th century, about Frank Lloyd Wright. So he had all kinds of training to engage with your sources, and but the ultimate goal was writing this history. Also had a minor in the historical foundation of quantum theory. So all kinds of things. But it is important also to certainly it is a young field at the one hand. And what I say is the young field has roots that go a long way back, and that we need to understand. And that is first, also I have a recommendation that when implementations take place, when changes are take place in healthcare organizations, that they try to document them in one way or that they or keep the documents on which they base decisions. Why would we have adopted a electronic health record? What were the circumstances in which those happened? What was the influence of governments? Did they had a decisive influence on? Was it through planning of resources that is a requirement? Doctors complain a lot about administrative burden, but they have to understand that much of that burden is not intrinsic to healthcare computing, but rather to the requirements that are imposed on them by various bodies. And that goes a long way back.
Well, fascinating. As I say, if you don't understand history, you repeat the same mistakes, and I think we've seen a lot of that in the health informatics industry, looking back at things. Yeah. I'll open that up for questions.